Good evening and welcome. My name is Katie Jaggers-Ludwig. I've been involved with Suburban Hospital for over 20 years on a volunteer basis. In the last 3 years, I have been proud to have served as the Foundation Board Chair in 2019, 2020, and 21. I have spent most of my life here in Bethesda, Maryland, where Suburban has treated family and friends with passion, unique expertise, and kindness. We are so blessed to have such a jewel of a hospital, Suburban Hospital, in our community. Thank you for joining us this evening for the 20th Annual Women's Health Symposium, Interconnection of Mind, Heart, and Body, in honor of Women's Heart Month. I think it goes without saying, the past 2 years have been stress and anxiety filled, and us as women often look after those all around us, kind of making ourselves second. So now it's time to tune into us. With the demands each of us face in our daily lives, let us take a moment to learn how stress can affect our heart, body, and mind. Tonight, Dr. Erin Donnelly-Mikos, Director of Women's Cardiovascular Health at Johns Hopkins Hospital, is with us to discuss how psychological factors can affect women's heart health and what we can do in our lives to improve and strengthen our mind, heart, and body connection. Before we begin, I want to review a few housekeeping items. We will do our best to answer all of your questions throughout the program. If you do have a question, please use the question and answer box located at the bottom of your screen. We will dedicate the last 15 minutes of our program to answering questions. Tonight's presentation is being recorded. It will be available in the coming days for you to view again or to share with your family and friends. Your feedback is very important and helps us continuously improve these offerings. At the end of the program, there will be a link for a brief evaluation that will appear on your screen. Please take a moment to complete the evaluation. It helps us at Suburban planning future programming for our community. So I thank you ahead of time for doing that. Lastly, it is with heartfelt thanks. We want to thank the J.B. and Maurice C. Shapiro Endowment for Women's Health in supporting Women's Health Symposium for 20 years. Thank you, Shapiro family. And now I would like to introduce our speaker, Dr. Erin Mikos. Dr. Mikos is an associate professor of medicine within the Division of Cardiology at Johns Hopkins School of Medicine, with joint appointment in the Department of Epidemiology at Johns Hopkins Bloomberg School of Public Health. She is the Director of Women's Cardiovascular Health and the Associate Director of Preventative Cardiology with the Johns Hopkins Cicerone Center for the Prevention of Cardiovascular Disease. Dr. Mikos is a Fellow of the American College of Cardiology, a Fellow of the American Heart Association, a Fellow of the American Society of Echocardiography, and a Fellow of the American Society of Preventive Cardiology. Dr. Mikos has authored or co-authored over 400 manuscripts in peer-reviewed journals and is internationally known leader in preventative cardiology and women's health. Dr. Mikos completed medical school at Northwestern University in Chicago, Illinois, and then completed both her internal medicine residency and cardiology fellowship at the Johns Hopkins Hospital in Baltimore, Maryland. She also completed her Master's of Health Science degree in cardiovascular epidemiology at the Johns Hopkins Bloomberg School of Public Health. Dr. Mikos, it is with gratitude and honor to have you speaking tonight. Please, the floor is yours.
Thank you very much for that kind introduction. I'm going to share my slides. Let me get it into full screen mode here. Oops. All right, so hopefully you can see these slides. So as you heard, I'm going to talk a little bit about cardiovascular disease prevention, and I'm going to focus on psychological health. So the problem, and this is why we have Heart Month and having this symposium, is that cardiovascular disease still remains the leading cause of death in women, accounting for about 400,000 deaths each year. And while many women fear breast cancer, which is indeed a terrible disease, my mother is a breast cancer survivor, and my cousin, there's women are tenfold more likely to die of cardiovascular disease than breast cancer. And there's 44 million women living with cardiovascular disease in the United States compared to 3.5 million women with breast cancer. And the reason why I like being a preventive cardiologist is that we think up to 90% of cardiovascular disease is preventable through modifiable risk factors. Now, you may have seen statistics from the American Heart Association. This is United States data about deaths from cardiovascular disease. And cardiovascular disease includes both stroke and heart disease. So in the 80s and 90s, cardiovascular disease mortality was going down in men. They were getting treatments like statins. Their cardiovascular risk was being paid attention to. But things weren't looking good for women. Their cardiovascular risk was being ignored, and cardiovascular mortality was on the rise in women till around the year 2000, when this really came to attention, and there was the release of the first prevention guidelines specific for women. There's also campaigns like the American Heart Association's Go Red for Women campaign. And after this point, there was a stark decline, a dramatic decline in cardiovascular death in women, as well as continued decline in men. And again, this is why I like being a preventive cardiologist, because we were able to really impact cardiovascular death. But unfortunately, we all really need to be very concerned what's happening now on this right-hand side of this curve since 2010, that we are no longer making progress in reducing heart disease death. In fact, we're not even stagnated. There's been now an uptick, a rise attributed to the epidemics of obesity and diabetes and sedentary lifestyles. And when you look at rate of change, the fastest growing increase in heart disease death rates is actually in middle-aged women, which was increased 7% up since 2017. I know this is an age range that I fall in. This is often a very busy time in a woman's life. They may have dependent children and aging parents. They may have a spouse or a partner and careers. And often women tend to focus on everybody else in their lives. But it's important not to neglect their own heart health and to make women a priority. So there's different types of cardiovascular disease. I'm going to be largely focusing on atherosclerotic cardiovascular disease, which is the leading type of heart disease. So atherosclerosis is a disease where plaque builds up in the arteries over a lifetime related to risk factors, which I'll show on the next slide. And it can either narrow blood flow, so people can have symptoms like chest pain or called angina if there's not enough blood flow in the heart arteries. Or sometimes, even if there's not a major narrowing, if there's plaque, the plaque can break off suddenly and form a blood clot that leads to a heart attack. And this can occur even in arteries that have plaque but are not even that narrowed. And this is why we need to prevent and treat all plaque. So you may be familiar with the traditional risk factors for cardiovascular disease: increasing age, smoking, having high cholesterol, having high blood pressure, having diabetes, having a family history of early heart disease. But we're also becoming aware of other newer risk factors. I'm interested in women's health, and we're learning about the impact of preeclampsia and gestational diabetes on future heart risk, autoimmune diseases like lupus or rheumatoid arthritis. There's a lot of impact related to social deprivation, and I'm going to talk today about the impact of stress and mental health. But before I get to that, I just want to touch on a few other risk factors. Even among traditional risk factors, sometimes women are impacted more. For example, diabetes is a risk factor in both men and women, but it's a greater risk in women. These are different types of cardiovascular disease. This myocardial infarction means a heart attack, and having diabetes confers a 4-fold increased risk in women and a 2-fold increased risk in men. So it impacts women's risk more. The same thing with smoking. Smoking is not good for anybody, but it increases the risk of a heart attack more so in women than in men, particularly younger women. And additionally, women experience unique risk factors throughout their lifespan related to menarche, which is the onset of menses, if it's early, related to hormones and pregnancy and menopause that men do not experience. And some other time I give a talk focused just on these. Briefly, I just want to talk about how we assess risk before I get into mental health. There are calculators as a starting point where people put in their age and their cholesterol, their blood pressure, and whether they're diabetes or smoking. And it gives an estimate of one's 10-year risk for heart attack and stroke. This is a good starting point. But this is, all shows you all those other factors that are not in this score. So this score can't underestimate risk. And that's why it's important to consider those other factors. But sometimes risk is uncertain. And when I see individuals for prevention, if they're not known to have heart disease and we're trying to figure out if they have heart disease or not, sometimes we order a test called a coronary calcium score. This is done by a non-contrast CT. It's a very low dose radiation protocol. It's gated in between the heartbeat. So it's much lower radiation than a full lung CT. But as plaque is building up in the arteries, a certain percentage of it can become calcified. We can't see the cholesterol plaque, but we can see the calcium because calcium shows up right on x-rays. It's these white spots. And this is a marker that there's atherosclerosis there. And it turns out in multiple studies, and I'll show you one of them, that the amount of calcium in its artery is very predictive of future risk for heart disease, likely because it's capturing plaque atherosclerosis directly. And it's really integrating, that buildup of risk factors over one's lifespan related to genetics, both the traditional and the newer risk factors. And whether one has disease or not in the arteries kind of determines how intensive we are with prevention and whether we recommend therapies such as statins. And this is one such study I was involved in from a study called the multi-ethic cohort of multi-ethic study of atherosclerosis. And we looked at event rates of having a heart attack and stroke over 10 years. And this red line is a threshold that we generally consider in cardiology to be a high enough risk that patients would benefit from statins. So women with a 0 calcium score here in this light gray line had a very low risk of a heart attack or stroke over the next 10 years of follow-up. It wasn't a 0 risk, nothing, there were some events that happened. So a 0 score is not 0 risk, but it was low enough risk and kind of below this threshold that many women and their providers may wish to defer statin therapy if that is their choice, if they're otherwise, lower risk. But on the other hand, the higher the score, the higher the event rates, and any score above 0 crossed this threshold in 10 years. So I really recommend a statin for anybody with a score above 0, and particularly for higher scores above 100. So that's one approach I do in clinical practice. And of course, when I see individuals for prevention assessment, we talk about all the ABCDs of prevention. We assess risk. Aspirin we use in people with known disease, and selectively for prevention in patients at high risk. We want to maintain a blood pressure less than 130/80, optimize cholesterol. And again, if risk is uncertain about whether we should start a statin or not, we can consider that calcium score. Smoking cessation, promoting a healthy diet and weight maintenance, controlling blood glucose, and making sure people are getting adequate physical activity. And just on one note, though, that unfortunately we're losing ground in awareness that heart disease is women's leading cause of death. And so I'm glad you're on the symposium. These are surveys that the American Heart Association has sent out to women over the years. And back in 2009, 65% of women knew that cardiovascular disease was the leading cause of death in women. And this declined to only 44% in 2019. So we're unfortunately losing awareness. More women are likely to think cancer is their leading health threat. And this reduction in awareness is particularly noted among Hispanic and Black women, and also among younger women who arguably we could do the most for prevention if we start at a younger age. And so we need to double our efforts in getting the message out there. So I was asked to talk about mental health. I'll first just mention one of our studies that we published last year. We have another one out just looking at the rise in terms of heart attacks associated with individuals who have mental health disorders. And we did see that over this decade period that depression here in the yellow and anxiety is on the rise among patients that present with heart attacks. And additionally, we did see that women were suffering from depression, anxiety much more, almost twice as likely more than men. And that there was also some disparities among different racial ethnic groups. It's really important, though, that we focus on mental health interventions, and that, especially after a heart attack and before a heart attack, that we prioritize addressing mental health. Because after a heart attack, women are actually more likely to be rehospitalized. So women are here in the gray bars, and whether they were under 55 in the solid lines or over the age of 55 in the dotted lines, women were much more likely in the study to be rehospitalized. And the authors found that one of the major contributors was a greater psychological stress in women, as well as they had their risk factors less well controlled. And just to mention, of course, about the warning signs of a heart attack, even though women do get a lot of other symptoms, in most heart attacks, there is still some discomfort in the chest. It's not always pain. It can be a squeezing, a pressure, a heaviness, a crushing sensation, but it can be associated with discomfort in the neck or the arm or the back or the jaw or the shoulder, with shortness of breath, feeling lightheaded, feeling one might need to vomit, or feeling very nauseated. These are all can be symptoms of a heart attack. And if these come on suddenly and are persisting, to be calling 911. So the mind, heart, and body are very deeply connected, and so that it's important that we consider the whole person and not consider cardiovascular disease in isolation. Depression can lead to having a poor diet, less likely to do preventative therapies like physical activity and exercising and getting preventative visits. And in turn, poor coping habits can also increase the risk of heart disease. Conversely, heart disease can also increase the risk of depression. Having a major life event like a heart attack, can obviously exacerbate or potentially induce a mental health disorder like depression or anxiety. And that's why it's important that we treat the whole person. But conversely, positive things like exercise, which boosts endorphins, healthy mood can boost mood and happiness. If someone has a sense of purpose and a positive outlook on life, they may take better care of themselves, get better sleep, not smoking, eat healthy. And those factors can also reduce the chance of heart disease. So when we think about the impact of psychological health on cardiovascular health, there's both direct and indirect effects. So the indirect effects are that individuals who might be experiencing a negative psychological state, stress, anxiety, depression, may have, as I mentioned, poor coping habits such as increased smoking, increased alcohol, less activity, poor sleep, not following through with preventive visits. But there's also can be direct biological effects, as I'll show in an upcoming slide. People under stress can have an increase in heart rate and blood pressure and an inflammatory response. Their body's under this fight or flight response, and this can lead to poor cardiovascular health. On the other hand, positive factors, even independently of the absence of negative factors, can have favorable effects. So again, as mentioned, people in positive psychological health may have favorable behaviors like eating better and not smoking and exercising, but also positive psychological health can help, lower heart rate and lower blood pressure and lower inflammation in the body and have a positive biological feedback that can improve cardiovascular health. So talking first about the negative factors. So again, as I mentioned, there's both behavioral factors and there's also biological factors. So people under stress can have this revved up system, revved up sympathetic system, disruption of the hypothalamus, pituitary adrenal axis. They're on high alert, sort of having this chronic stress state. So there's going to be a low grade inflammation, and they might have be more likely to form blood clots and have stiffer arteries. And this can lead to ischemia or insufficient blood flow to the heart muscle tissues. So we can't talk about health without talking about stress. And stress is the body's response to, it can be a physical, a chemical, or emotional or environmental stress, but it does include real physiologic changes. So it's not all in one's head. This is experienced by physiological changes in the body. Stress can be both short-term and long-term. And I will mention not all stress is bad. So a little stress is good. This helps us get deadlines done and accomplish tasks. And we can't eliminate all stress in one's life, but certainly if it's chronic and persistent and affecting one's ability to function, this can be detrimental. And of course, there's all kinds of stress. It's not uniform. We've all experienced some of these in our relationships or prior trauma, financial stress, employment-related stress, neighborhood or society stress, political stress, discrimination, or unexpected natural disasters like the pandemic we've been living in. And as I mentioned, these are some of the physiological changes, a release of stress hormones that can lead to elevated heart rate, elevated blood pressure, increased use of oxygen, tense muscles, triggering inflammation, dysregulation of blood glucose, which can lead to more fat deposition around the waist and the more worrisome fat that when one puts around their abdomen, their visceral organs. And of course, stress can present itself in physical symptoms, having low energy, feeling nauseated, GI issues, having aches, pains, tense muscles, trouble sleeping, sweating, chest pain or palpitations, hair loss, weight gain or loss, acne, irregular periods, having disinterest in sexual relationships, having headaches. All of these can be signs of stress. Now, stress is particularly taking a role on women. Women are 38% more likely to have a cardiovascular event when experiencing high stress. Again, women with greater stress have a sort of worse cardiovascular profile. The pandemic made everything worse. Surveys say that 77% of women said their workload increased at their job and that they were doing more caregiving hours at home. And actually, sadly, more than half women plan to quit their job due to poor work-life balance. So we're losing a lot of women from the workforce. And we're losing tremendous talent, which we need to fix this problem and be able to support women better in the workplace. This is exacerbated, particularly women of color are more likely to be laid off, which is a threat to their financial security. And there are women of color and single moms are more burdened by housework and caregiving. And women of color are also disproportionately represented in lower wage jobs, making them less likely to have benefits, which all compounds stress in a synergistic fashion. Now, I wanted to also point out this one study is that we think about stress as something we experience in our head that we feel emotionally, but there's actual physical changes. In this study, the amygdala is a part of the brain that is the emotional response. And in these individuals who had high amygdala response, suggesting they were under high stress, they were much more likely to have a subsequent cardiovascular event, a heart attack or stroke over the next few years, compared to people who had evidence of low stress on their brain PET scan. And when you looked at inflammation in the heart and in the bone marrow, which releases inflammatory cells, women under high stress were much more likely to have inflammation. So this shows that there's really, truly physical changes with objective measures by stress seen on brain imaging. And there's other studies that have looked at stress testing and looked at mental stress activities and showed that women were more likely to have an abnormality on their stress test, their cardiac stress test, if they were under more mental stress in this linear association. And so we'll talk about simple ways of coping with stress, but again, there's no easy solution, and things work for different people. But maintaining a balanced diet, not smoking, getting physical activities can be buffering. Remembering that it's okay to say no. It's important to carve out time for relaxation. Social connections are really important. It's important to set realistic goals and expectations. Remind ourselves about the things that we do well, getting adequate rest, and making sure we keep up with our preventative health visits. Just a note about sleep as well, that sleep is really important, and both short sleep And excessive sleep may be associated with cardiovascular disease. The excessive sleep may be potentially a marker of people under stress or depression, where the optimal amount of sleep was between sort of 6 to 9 hours, with both short and long having a greater risk of a subsequent heart attack in this study. Now let's focus on the good things. There's a lot of also beneficial things for being in good psychological health. And again, wellness is not just the absence of disease. Having well-being is the experience of good mental health, high life satisfaction, a sense of meaning or purpose, ability to manage stress. It's not just the absence of psychological distress. And so this is all from our AHA statement that I was a part of a few years ago, these particular slides. So again, positive psychological health, such as happiness, optimism, sense of purpose, gratitude, well-being, mindfulness, again, has both favorable behavioral activities and also biological activities, better blood pressure reduction and better glucose control. These are some studies that followed and looked at risk of a heart attack over 10 years. And interestingly, individuals who were more optimistic, here in the green bar, were much less likely to have a heart attack compared to people who were pessimistic. And again, these are associations. Associations don't always mean causations, but definitely there was an association with less heart disease risk in people who are more optimistic. The same thing with having a sense of purpose. So if one feels like they have a purpose in life, they have goals in life, much more satisfaction in life, they were less likely to have a cardiac event compared to people who feel like they have a low purpose in life. Social support is really important in both men and women, but as individual social networks increased, there was also seemed to be a buffer with less cardiovascular death in individuals who had more social connection, with social isolation being associated with risk. So how can we cultivate a positive framework? Again, they're both these biological processes and I'm really a fan of things like yoga and mindfulness, meditation, things that we can help effectively regulate our emotions, stress management, having positive social relationships. And for individuals, who have significant psychological distress, it is really important to also reach out. There's trained psychological counselors and therapists that can help. And individuals who are able to make these changes in behaviors do have reduced risks of cardiovascular disease. So for diet, what we recommend in our prevention guidelines, and again, there's many healthy diet patterns that fit this, but having higher intake of fruits, vegetables, legumes, nuts, whole grains, and fish, kind of a Mediterranean style diet has been shown with the lowest risk of cardiovascular disease, but also a DASH diet, or this can be modified for a healthy vegetarian diet. Plant-based diet can also meet these criteria. We want to reduce saturated fats. Those are the bad fats that raise the bad LDL cholesterol, but it doesn't have to be a low-fat diet. It can be replaced with the healthier mono or polyunsaturated fats that we see in fish and nuts and olive oil and avocados, the healthier fats. So it's really sort of a moderate fat diet. We want to reduce cholesterol and sodium and minimize processed meats, the refined carbs, the simple carbs, focusing on the complex carbs that are in fruits, vegetables, and whole grains, and reduce sweetened beverages and avoid trans fats. And so this is the pattern that's been associated with lower risk of cardiovascular disease. And then the importance of physical activity. I'm definitely an exercise enthusiast. It's so important, not only for reduction in cardiovascular disease, but reduction in cancer and musculoskeletal disorders and diabetes. And also being physically active can be a buffer against psychological disorders as well. And one does not have to do vigorous exercise to meet cardiovascular benefit. We get most cardiovascular benefit from a moderate intensity activity, including brisk walking is a moderate intensity activity most people can do. And as again mentioned, mindfulness can be helpful to help regulate emotions. This is more being attention to the present moment, having self-awareness, and this can help, been shown in studies to help maybe lower blood pressure and lower heart rate, taking deep breaths and restoring the autonomic nervous system, the vagal nervous system, associated with potentially reduction in cardiovascular disease risk. So, give yourself permission to ask for help, say no more often, try to feel less guilty. I struggle with all of these myself too. Our time is a valuable resource. We need to protect and carve out time and let go of the long list of shoulds. All of us need to take some time to unplug from our devices and maybe take a social media break and a news break if it's starting to create more anxiety than good. Now, resilience is something that we can all practice. It can have some buffer against life stresses. It's not, entirely the canary's fault for not surviving in the coal mine. We do need to fix the environment as well if we're not in a healthy home or work environment. But having resilience is having a greater acceptance of life situations, greater adaptation to uncertainty and change, greater self-care, and increased motivation to make lifestyle changes. And this is something we can practice and we can learn. And self-care isn't selfish. You can't pour from an empty cup, and we can't help all the other people in our lives if we don't take care of ourselves first. So talk to your doctor about any health concerns, including symptoms of stress. Many women don't bring this up. And if you're feeling depressed or anxious, it's okay to talk to your primary care doctor first. They may be able to help you, likely be able to help you. Some may refer out to see a specialist. And talking to a therapist or life coach if you feel overwhelmed and need help managing stress or feel mentally unwell. And so I hope that we can all set some goals, setting a bedtime alarm, getting good sleep, getting fresh air, moving our body more, mention our mental health to our clinician, practicing gratitude. I keep a gratitude log every day, no matter how difficult the day is. There's some things to be grateful for. Make sure our snacks that we're eating, feeding our body with healthy fuel, finding ways to help others. Often if we help others, it takes our mind off our own problems and can be very rewarding. And there's something very simple about taking 3 mindful breaths that can help, again, regulate, stimulate the diaphragm, increase vagal tone, bring down that heart rate and blood pressure. And February, the American Heart Association is having this Reclaim Your Rhythm. So trying to get back into the rhythm of living longer, healthy, fuller lives, because losing even one mom, sister, friend, or neighbor to cardiovascular disease is too many. So I'll thank you, and I'll stop here so we can do questions.
Thank you so much, Dr. Mikos. That was wonderful. Very much appreciated, and a wealth of information. I do have a question here. How would you explain broken heart syndrome and how it affects women differently than men?
Oh, yeah. So there's been a lot of data that suggests that women seem to be impacted by stress more so than men, and stress cardiomyopathy is one of them. So stress cardiomyopathy is an acute cardiovascular disorder where in the setting of a stressful event, it can be an emotional stress. So somebody hears really bad news or something traumatic happens. It also can be in a physical stress, but there is stunning of the heart muscle. And it presents like an acute heart attack. So often there'll be sudden onset of chest pain, and there can be EKG changes, and everything looks like a heart attack, and the heart's stunned. So cardiomyopathy means weak heart. And it's the other name of this disorder is actually called Takotsubo, because that stands for an octopus pot, where there is the shape of the heart is this ballooning, this apical ballooning from stunning. And in the beginning, when someone presents in the emergency room with this, it can look just like a heart attack. But when you look on angiography, the arteries are clean. There's no blocked arteries. So it's not a heart attack. And but people can be quite sick acutely with this and often need to be supported, in an intensive care unit or on the floor. But with medications and supportive care, the heart function can come back to normal. So this was a stunning. And we think that this is due to the catecholamine surge that stuns the heart. And interestingly, more than like 80% of stress cardiomyopathy affects postmenopausal women. So it seems to predominantly affect women and women after menopause. And we don't really know why. We think somehow related to the hormones and women's susceptibility to the injury to the heart from this catecholamine surge. So it's hard to think about what we can do to prevent this exactly. Of course, we want to try to prevent what stress that we can. We can't prevent all stress in life, but it's just another example about how stress can impact women's hearts more so than men.
Terrific. Thank you so much. I have another question that populated. Are elevated triglycerides the #1 risk factor for coronary artery disease and stroke? If so, at what level of increase begins that risk?
So triglycerides are an important risk factor, but more stronger risk factor is LDL cholesterol. So LDL cholesterol, we think is causally related to atherosclerotic cardiovascular disease. And we have overwhelming evidence from genetic studies, from animal studies, from observational studies and interventional studies that show kind of a direct relationship between higher LDL levels and increased cardiovascular risk. So across all the guidelines, the first target when we're looking at lipid panels is the LDL cholesterol. And now the decision of when we treat with statins kind of depends on the risk of the patient. So if they have heart disease already, we treat sort of regardless of what the value is. If the cholesterol is very high with the LDL above 190, we treat with statins. If a person has diabetes, they're high enough risk, we treat with statins. Or as I showed you, if they have plaque, like on a coronary calcium score. So the first goal is to get the LDL at goal. Now, triglycerides also predict risk even on top of people who are treated with statins with LDL. So this is a secondary target. The risk seems to, we consider above 150 high, but really risk starts to take off even in the normal range, even values sort of less than 100 in a graded fashion. Predominantly, the treatment for triglycerides, unless they're very high, above 500, we worry about pancreatitis, and we treat with fibrates, not so much for heart health, but for preventing pancreatitis. But in that moderate range between 150 to 500, we treat with a statin first, and we really focus on lifestyle because lifestyle can impact the triglycerides the most. So losing weight if you're overweight, exercising, cutting out those simple carbs, reducing alcohol, reducing breads, pastas, all those things can help lower triglycerides, making sure people aren't on medications like estrogens that can raise triglycerides. And then we can consider there's certain things like icosapent ethyl, which is a prescription type of a fish oil that can be used for treatment. So they do predict risk, but I would focus on LDL first, and then triglycerides are the second.
Thank you very much. We have another question that came in. What can be done to reduce coronary artery calcium aside from taking statins and a combination of vitamin K and D?
So the statins reduce the plaque. So coronary calcium is just a useful marker that there's plaque there. It's actually not the calcium that's the bad part. It's the cholesterol plaque that's filled with, fatty tissue and lipids and inflammation. And that's what can rupture and cause a heart attack. So statins, when we start treatment, can shrink the plaque. They remove the cholesterol, the lipid part out of the artery. They make the plaque more stable, less likely to rupture. But one thing to note is that the statin doesn't lower the calcium score. The calcium score, once present, doesn't go down. The statins shrink the bad part of the plaque, kind of leaves the calcium behind. And so once somebody has an elevated score, the calcium score is not a useful score to follow because it doesn't improve on therapy, but we know that statins reduce the risk of a heart attack by 20 to 30%. And so really, once we start statins, we focus on the LDL, making sure that's nice and low, because we know once you get the LDL low enough, plaque can regress and not progress any further. So the only time I really repeat the calcium score is if it's 0 and we don't start a statin, then I might check again in 5 years to see if it's still 0 and then start a statin. But really the important thing is lowering the LDL. It's not going to lower the calcium score.
Very good. Thank you. We have another question that came through. Could you briefly mention how hormones, and especially stress hormones, can affect women's heart health?
Yeah, so as I mentioned, some of the cortisol and the stress hormones can, increase blood pressure, lead to dysregulation of blood glucose. So this, is associated with increased risk of diabetes and cardiovascular disease. And that's why we talked about these coping mechanisms for reducing stress. Hormone therapy is a different story. There's some controversy about that, related to timing. We're not currently using hormone therapy after menopause for preventing heart disease, because in some trials that were conducted in older women, there was actually more harm than benefit. We don't really see that harm when women are closer to menopause, But in terms of menopausal hormone therapy, again, we don't use it for prevention of cardiovascular disease, but it's used in women who are closer to the menopause transition, who have significant vasomotor symptoms, hot flashes that are quite significant. It can be used for a short period of time to help manage those symptoms if woman is otherwise low risk for cardiovascular disease. But usually we wean women off hormone therapy once they're more than 10 years out from menopause or over the age of 65, because that was sort of the higher risk groups in the clinical trials.
Very good. Thank you. I believe this question loops back around to the coronary artery calcium conversation you just had. How old is too old for the change you described to make a difference? Is it worth the effort after 65?
Yes, I mean, in terms of prevention. So obviously atherosclerosis builds up over a lifetime, and we might have the most bang for the buck if we start prevention earlier, but it's never too late. And it's really important that we think about prevention through the whole lifespan. Again, not everybody needs a coronary calcium score. If somebody's high enough risk, we just treat with preventive therapy. Statins are safe and effective, and they reduce the risk of heart disease by 30%. So many people we just treat, especially if they're higher risk. I just mentioned that a lot of times there's some uncertainty. So people maybe have mildly elevated cholesterol. Maybe they have a family history, but everything else looks good. Maybe they had a history of preeclampsia, but they're, what is their risk now? So sometimes when there's uncertainty about risk, knowing whether there's disease or not disease can be helpful to guide decisions about how intensive we treat. Many patients I have with a zero calcium score, still take a statin because they want to keep their arteries clean. So this is really part of shared decision-making with the patient. So I do sometimes get calcium scores in people who are 65 and older if they're not already on treatment. If they're already on treatment and doing well on treatment, we just continue their preventive therapy.
Thank you. And I had another question that came across the screen. What suggestions can you offer for people who work 8 hours in front of a computer to reduce their stress and risk of heart disease?
Oh, I know this is, challenging for me too, as well. One of the things I do is I read echoes, ultrasounds of the heart, where I'm sitting in the computer all day when I'm not clinic seeing patients. So it can be challenging. Everyone needs strategies. I encourage, getting up, standing, walking breaks. Being able to, if you're holding meetings, do walking meetings, being able to stand up and, we do sort of this, for every, 20 minutes or 30 minutes of sitting, make sure we can get up and stand for 10 minutes. Different strategies work for different people. So for me, I have to do my exercise early in the day. I do at 5 a.m. I do my running, so get it out of the way before the work day, because studies have suggested that even though there's risk of sitting time and sedentary time, people who are overall physically active, their risk is lower, even if they have long periods of sitting. So while we want to, not have so much sitting time, if people can get an activity in the morning or lunchtime or evening, wherever they can get a block in time, this will offer some buffer, some protection, even if the day is spent sitting. So my big advice is, if you can't get activity, 8 hours during the day, to try to, get it in, before the day or the end of the day.
Have another question. Is there an increased risk of diabetes and or dementia if taking statins?
So there's no risk for dementia. That's been disproven. So actually statins reduce the risk of dementia, because a lot of dementia is due to vascular dementia. It's due to strokes, and statins reduce the risk of stroke. So actually statins can reduce the risk of dementia. Some of this misleading information had to do with observational studies. As I mentioned, observational data, associations don't mean causation. So many people who are older and frailer and have heart disease and risk factors, take statins, and because they have heart disease and because they're older and frailer, they also are at risk for cognitive dysfunction, but the medication wasn't related to that. And we've seen now in cognitive testing and clinical trials that there's been no change in cognitive scores. Now, the blood glucose is interesting. So statins don't take people who are normal glycemic and make them diabetic. But there is a small bump in blood glucose with statins, about 5 milligrams per deciliter, small bump in blood glucose. So for people who are on the borderline, who are pre-diabetic, or usually people who have elevated body mass index, elevated blood glucose, that the statin could bump them above the 6.5% A1C, where they're considered diabetic, almost a chemical diabetes. But it's important to note that there's overwhelming evidence that even among diabetes, that statins reduce the risk of strokes and heart attacks and vascular disease. So the benefits outweigh the risk of that tiny blood glucose. So usually what I tell my patients is that we want to work on lifestyle changes of weight loss and exercise to counteract the small bump in blood glucose. But again, not everybody needs statins. That's why I said when there's risk uncertainty, I get that calcium score. If the calcium score is really 0 and their arteries look clean, if individuals really don't want to go on statins, then we just focus on lifestyle. But if there's already disease in the arteries, if there's already plaque, that's the nidus for a heart attack. And so we treat that a lot more aggressively.
Very good. Thank you. I have another question. Is it possible to reverse the effects of negative stress on the heart?
Yes, I mean, I think that, it depends what, if somebody's had a heart attack or not, whether there's any existing damage. But yes, all those things. So sometimes when we think about heart disease, we want to do a combination of lifestyle and medication. So, we even see this in patients who, for example, had a heart attack and participate in cardiac rehab. Cardiac rehab is so important. And many cardiac rehab, after a heart attack or a stent or bypass, in addition to all the medical things, so making sure one's blood pressure is controlled and cholesterol is controlled and their diabetes are controlled, have a physical activity, a fitness component, and often have a mental health component. So stress management has been integrated in many cardiac rehab programs. And I think that's really important, a part of taking the whole picture. Because if someone's under a lot of stress, it's going to make the other preventative interventions less effective. People are less likely to take their medications, or, their blood pressure medicines are not going to work as well if they're constantly, revved up and anxious. And so it's important to do both as a comprehensive approach.
Very good. Thank you. We have another question across the screen. Are you seeing more women with scardosis of the heart? And do you feel there is enough education about arrhythmia issues for women?
Yeah, so I'm not a sarcoid expert per se, so I'm not aware that sarcoid has been increasing, but I think there was another question about atrial fibrillation. So atrial, which is an arrhythmia. So the other part of the question was, is there enough awareness about arrhythmias? So atrial fibrillation is the most common arrhythmia. It increases with age. It's a little bit more prevalent in men than women, but women with AFib are much more likely to get stroke, because women are generally more likely to get stroke. And so it's really important that AFib is identified and that individuals are treated. If someone's at high stroke risk, they need to be on blood thinners to help reduce the risk of stroke. And importantly, though, that there's many modifiable factors that can help prevent AFib. So AFib is increased among people who are overweight or obese, who have hypertension, who are less physically active, more sedentary. So we know that, and who have sleep apnea. So maintaining a normal weight, not drinking too much alcohol, staying regularly active, these can, controlling blood pressure, these all can help reduce the risk of atrial fibrillation. But I focus my talk on atherosclerosis, but yes, arrhythmia is another type of cardiovascular issue, and it also impacts women significantly as well.
Terrific. Thank you. I have another question that came in. Do you have any suggestions on dealing with hot flashes? I'm 69 and the hot flashes are nightly. I am sleep deprived.
Yeah, so of course, I'm a cardiologist, so I'm lucky to work at Hopkins with our menopause clinic and our GYN colleagues. I work with Dr. Wen Shen, who's wonderful, who directs our menopause clinic. So vasomotor symptoms can really impact women's quality of life. And I think a lot of doctors don't ask women about this, but they can be quite really disabling. And there's a approach related to first, lifestyle changes. So hot flashes are greater among people who are overweight. So weight maintenance, exercise, there's different lifestyle changes. There's also some non-hormonal therapy, including sometimes taking some antidepressants, SSRIs can help regulate some of the heart flashes. So there are some non-hormonal medical therapies. And then for select women, we do use hormone therapy. Generally, we use it, as I mentioned, people closer to menopause who are, within 10 years of menopause and under the age of 65. Selectively in older women, that's when I do a calcium score. If they have no plaque in their arteries, the calcium score is 0, then I do think they're in lower risk. Because in selective cases, if nothing else works, and that's what works for them, as long as they're at low risk for cardiovascular disease. And so this is a conversation we make with the patient, their GYN doctor, and their cardiovascular risk assessment.
Very good. Thank you. I have another question across the screen. What conversation should we have with our healthcare provider when it comes to our physical and emotional health?
Yeah, so I think first of all, it's important to know your numbers and make sure that you get all the screening for all the traditional factors. Make sure you know your lipid panel. You discuss what your target should be for your cholesterol, your blood pressure, your glucose. It's important to discuss all your symptoms. So often women's symptoms are ignored. And if you're having any of this discomfort, heaviness, tightness in the chest or the jaw, the arm with exercising, it's really important that you discuss this with your doctor. These could be symptoms of angina or ischemia. And women are more likely to be told that their cardiac symptoms are from a non-cardiac source. They're more likely to be told it's due to anxiety or stress. Note that stress can exacerbate real underlying heart disease. So people can have heart disease and stress makes it worse. And so, it's important that cardiac disease is excluded first before we attribute all their symptoms to being just stress or just anxiety. So that's really important. And then for individuals who have significant mental health distress, to discuss this with your doctor, because there are resources. There's both, non-pharmacological therapies such as, counseling and therapists, and there's also, pharmacological options as well to help regulate mood. So it's really important that all of this is discussed.
Very good. Well, we have a couple more questions that came through, and we still have just a couple more minutes. Next question that came through: when should women in their 30s and 40s start seeing a cardiologist, and should they?
Well, I think it depends if they have cardiovascular risk factors or not. So most cardiovascular screening initially is done through your primary care or one's GYN. So measuring the blood pressure and the cholesterol and all those things. But individuals who have symptoms of cardiovascular disease or strong risk factors, such as a strong family history, or if they have elevation, like 1 out of 250 people have something called familial hypercholesterolemia, where they have a genetically very high cholesterol, and you won't know until it's tested. And so that's those kind of advanced lipid disorders should be seen. If someone has elevated lipoprotein little a, those should be seen. I also am interested in seeing women after an adverse pregnancy outcome. So if they had preeclampsia, they're at much higher risk for later life cardiovascular disease. So it's important that they get follow-up to get their blood pressure checks after delivery. So not every woman in her 30s need to see a cardiologist, but they do if they are identified to be at elevated risk. And that's why it's important to start with your risk discussion with your primary care doctor. And for the calcium score, I'll just mention, I tend not to do that until people are 40 or over. It takes time for plaque to calcify. And so in younger individuals, even if they have the beginning of plaque, it might not have calcified yet. So generally, we do the calcium score over the age of 40 and not so much in younger individuals, where we really focus on the lifestyle changes.
Very good. And now I have a question. How is it possible for a young vegan to have high LDL cholesterol?
Genetics. So most of your cholesterol, about 80% of your cholesterol, is made by the liver. And so not what you're taking in with your diet, but by the liver makes its own cholesterol. And this is why drugs like statins and other drugs inhibit cholesterol synthesis in the liver. There, as I mentioned, 1 in 250 people, so that's pretty common. 1 in 250 people have an autosomal dominant gene in familial hypercholesterolemia, where their LDL is above 190. And it's really important this is identified and treated because these individuals have very high risk of cardiovascular disease later in life. And we have lots of treatments. Statins are the first line treatment, but now we have actually a lot of other treatments for LDL cholesterol, which I didn't get into today, but we have PCSK9 inhibitors. We have some new therapies on the horizon. So, even though genetics plays a strong role, what you eat does matter, because if you have genetic susceptibility to have high cholesterol, and then you have a poor diet on top of that, that's just going to make the problem worse. So about a healthy diet can reduce cholesterol, about 20 to 30 milligrams per deciliter. So it can make an impact. But for some people, if they have such a high genetic risk, they might not still be able to get it down to desirable ranges and might require drug therapy. But there's lots of other health benefits with eating a healthy diet, even if it can't sufficiently lower cholesterol enough.
Very good. Thank you, doctor, very much. In light of the time, we are and trying to be very cognizant of our time and staying within our hour. I do want to encourage our panelists, if there are any questions we have not answered, to please flush them through, and we will get answers back to you with your questions. But I did want to thank you, Dr. Mikos, for sharing your time and your knowledge with us tonight. It is so incredibly valuable. And I want to thank the panelists for joining us this evening. We hope that it was informative and helpful to you, and that you will hopefully remember to do that survey at the end, as we do want to make sure these programs are beneficial to all of you. Please take care of your heart health and overall wellness. And I want to thank you all again so much. Please stay heart healthy and safe. Good night, everybody, for being with us tonight. Thank you.
Good night.